Good. Record is allowed. Sharing is allowed with pleasure. Okay. Candidate number 1, are you there?
Yes.
Okay. Bismillah. Inshallah, in today's session, I will try to cover some neuroradiology cases. So I want the first 3 or 4 candidates, all of them are ready. Dr. Aisha, number 2, ready? Number 2, 3, 4. Any one of these candidates are ready?
I am ready, Doctor. I'm number 3.
3 and
I'm
4.
ready, candidate 4.
Okay. Candidate 2?
Yeah, I'm ready. Yes.
Good, good, good. Okay. The first 4 questions, one for each one of you. Okay. Candidate 1,
Yeah.
control, please.
Okay.
Okay. You have the control. Just a minute, just a minute. I will minimize something with me. Okay, you can start.
All right. I'm presented with sagittal MRI of the spine, of the cervical spine.
Okay.
Okay, so I can see that there is an expansile intramedullary lesion in the cervical spinal cord at levels at vertebral level C2 to C4. So this lesion is mostly hypointense on T1, and it appears to be ovoid in shape or oval in shape. So there are adjacent hypointense areas, both superior and inferior to it, suggestive of edema. There is no extension to there is no other lesion noted in the remaining aspects of the spine or the spinal cord. The demonstrated posterior fossa, that's the cerebellum, as well as the medulla, and the inferior pons are normal. There is straightening of the normal cervical lordosis. However, the vertebral heights and signal intensities are not, they're a bit reduced, but to make an inference, I'll have to compare with others. So my findings in this image is that of an expansile intramedullary lesion with adjacent edema. I would like to check this on C2 and on a T2 sequence as well as on T1 plus contrast.
I will show you the T2 now. I just leave the mouse,
Okay.
Okay. T2.
All right. So on T2, I can the image is once the lesion is once again demonstrated, appearing mostly hyper intense on T2. However, there are some signal void areas at its inferior aspect, as well as its inferior aspect. This suggests a hemosiderin cap. So I'm looking for any other. There is no other associative feature in this image. So I would like to assess it on the T1 plus contrast.
Okay.
As well as,
okay. Give me a provisional diagnosis from these 2 sequences.
Okay. So considering the aforementioned characteristics, I'm thinking of an intraaxial lesion, and my main diagnosis is ependymoma. My differential is an astrocytoma. However, I expect this to be more eccentric. A hemangioblastoma is also a differential. However, I do not appreciate other features like flow voids. So to proceed, I will compare with previous images, and also in this current study, I will check the rest of the neural axis to check for other lesions, whether it is solitary or multiple. So and to rule out
what other lesions you want to look for in such case?
Okay, if it were syndromic, for example, there might be other features to suggest neurofibromatosis type 2.
Excellent, Elos. Excellent. Okay. I will answer after all 4 cases. Candidate 2, please. Ask for
Yes, can you
control.
hear me?
Yes.
Yeah, I'm here.
Ask for control.
Okay. I have requested the control.
Okay, accept. You can scroll.
Okay. Okay, so I'm provided CT cervical spine, sagittal images. These are T1 weighted images. I'm scrolling. I can see that there is evidence of spinal cord expansion and at the mid cervical level. I can see that the signal intensity of this lesion, which is involving the mid cervical level, it appears iso to hypointense. Now I am scrolling again to look for any other associated lesion. I can see that foramen magnum appears normal. There is no evidence of cerebellar tonsillar herniation. However, I can see some hypointense extramedullary areas noted within the upper thoracic region. Okay, now I want to see the T2 weighted images, and if the post contrast images I can see.
I'll give you T2.
Okay. Okay, so on T2 weighted images, I can see that the abnormality I have noted previously, it appears hyper intense. So the abnormality is T1 hypointense and T2 hyperintense, causing significant cord expansion, and I can also see some hypointense areas which are present in the intradural but extramedullary region. So I would like to see the post-contrast images, and then I will go towards my final diagnosis. I
Any
cannot
professional
see any other.
diagnosis from these 2 sequences? Any professional diagnosis?
So I would like to give the differential diagnosis of astrocytoma.
Why astrocytoma first?
Because it is low on T1 and high on T2, but keeping in view the appearance of the lesions which are present in the extramedullary space, I would also think of some hemangioblastoma.
Maybe there is artifact here.
Okay.
CSF flow artifact. Okay.
As my other differential would be ependymoma, but I cannot see any T2 hypointense hemosiderin cap, or I cannot.
Any other differentiating features
Of ependymoma and astrocytoma? Okay, the astrocytoma is slightly, it showed slightly irregular or infiltrating margins. However, ependymoma is well defined. And secondly, the astrocytoma also involve more spinal segments, I think. And the astrocytoma is slightly predominantly, I think, eccentric, and the ependymoma is central.
You can get another differentiating point from the appearance of the vertebrae.
Appearance of the vertebrae?
Yes, adult or child.
Okay, you want to know any other differential other than ependymoma and astrocytoma?
Yes. You can assume the age of the patient from the vertebrae.
Yeah.
This is young.
Yeah.
This is a child.
Yeah, this is young patient. So it is most likely than astrocytoma.
Okay. Good, yeah, boss. Good. Number 3, please, my friends, no one use the annotation. Just I will leave the mouse. Candidate 3 be ready?
Yes.
Just a minute, I will remove this annotation. Dr. Ayman, please. Yes. Thank you. Okay, candidate 3, ask for control.
Okay.
Start scrolling.
Okay. So I've been provided with surgical images, MRI. This is 81 with a sequence, and I can't see that what is seen to be this intramedullary lesions that is located within the middle part of the cervical spinal cord. It is of low signal intensity, opposite to the level of likely C4 to C5, and I can't see what is seen to be another lesion. I think this lesion seems to be, I don't know if it is if it is extra-axial intradural. I would like to correlate with the further images as well as the axial images because I'm very concerned that this may be um, extra-axial, however, intradural indication. I'm checking the rest of the spinal cord for me.
I'll give you T2.
Okay.
Just leave the mouse, please.
Okay.
Okay.
Okay, so this is a T2 with sequence of the same patient. Okay, I can't see that there is abnormal high signal intensity affected intramedullary using the spinal cord with expansion of the underlying segment of the spinal cord. And I can't see that what is seen to be cerviginous structure are seen on the posterior aspect of the spinal cord. This likely may representing third vessel. In my routine practice, I would like to correlate with the post contrast images because I'm very concerned about maybe this is hemangioblastoma due to the presence of serpiginous structure. In my routine practice, yes, I would like to correlate with the post contrast as well as the axial images. I'm very also concerned about maybe vascular malformation because it seems to be adherent to the posterior part of the spinal cord, AV vista.
Good. Does vascular malformation associated with intramedullary lesion?
No, in certain cases, maybe associated with expansion of this FC cord, maybe in certain cases, maybe Sornex. However, no, this is likely presenting research with a neural nodule with multiple serpiginous structures. So my principal diagnosis would be hemangioblastoma.
Good. You have to check the cerebellum. I will comment later. Candidate 4, please ask for control.
Yes, sir.
You have the scroll.
I'm provided with sagittal T2 weighted images of the cervical spine. I can see long segment of T2 hyperintensity involving the cervical cord, extending from the level of cervicomedullary junction up to the level of upper dorsal cord. I do not see any cord expansion. I do not see any T2 hypointense areas. I would like to view the T1 post-contrast images for this patient.
You noticed cord edema, but no lesions. No.
Yes. No, I do not see any solid lesion in this. I just see a long segment of cord edema.
Are you sure no masses?
No, I do not appreciate any solid lesion. I just appreciate a long segment of T2 hyperintensity involving the cervical cord.
Okay, just a minute, leave the mouse. Okay, what about this area? Is it normal?
I cannot see the cursor.
Okay, the upper dorsal vertebrae. Look at upper dorsal vertebrae. Upper dorsal cord. Is it normal?
No.
No problem, no problem.
Yeah.
Okay.
So, an ill-defined T2 hypointense intramedullary lesion is seen in the upper dorsal cord at the level of D2 vertebral level.
Good.
I would like to.
I'll give you another image, another sequence. This is a localizer. Okay, you can scroll. Just I think 2 or 3 images. Yes.
So I'm provided with the localizer images of this patient and um, I can
It didn't help you so much.
no, sir, it is
Okay.
not helping.
The mediastinal vessels looks normal, right?
Yes, the mediastinal vessels show normal
Okay, just a
flow.
minute. What about the left lung, the left hilum? Let me give you this slice.
I can see an T2 hyperintense lesion involving the left hilum.
Yes, and the mass below your mouth, your pointer. There is a mass.
Yes, I can see a T2 hyperintense lesion which is seen in the left hilum and extending in the infrahilar region.
Okay, good.
So I would like to review the T1 post contrast images.
Can you correlate these findings together?
Okay, based on these imaging findings, my possible differential would be intramedullary metastasis from a left hilar malignancy with the adjacent cord edema in the cervical dorsal cord.
Okay, okay. I will now
And
revise. Very good, dear bosses. Stay with me. You have another 4 cases, but I will revise this case first. This is a differential diagnosis of intramedullary spinal mass. The first one will be ependymoma. Ependymoma or astrocytoma or any intramedullary mass characterized by expansion of the cord. This is a buzzword here. It's expansile lesion within the cord associated with some edema. Ependymoma relatively well defined as compared to astrocytoma. But there is a specific sign, as our friend mentioned, the low signal intensity cap, hemosiderin cap, at the borders of the lesion. It's highly suggestive of ependymoma. Also, the definition and the location in axial, usually central, and the age group. It's in adult patients. Unlike astrocytoma, usually in a child. So use the appearance of vertebrae as a marker here for age and mention the age of this patient is young because of the appearance of vertebrae. There is expansion of the cord, usually homogeneous, unlike ependymoma, no cystic changes, no hemorrhage, and after contrast, both solid component will be enhancing. Okay, so the first 2 intramedullary lesions, astrocytoma in younger age group and in older age group will be ependymoma. Another lesion will be hemangioblastoma. Hemangioblastoma characterized by these low signal intensity serpiginous structures surrounding this lesion. Very good to mention the diagnosis of a malformation, but usually malformation not associated with enhancing lesion. If enhancing lesion intramedullary, this most likely a hemangioblastoma. In any one of these cases, rule out syndromes. Please, you have to mention. I will look at the visualized part of the brain. Here in hemangioblastoma, I will look for the cerebellum in looking for any enhancing nodules or cyst with enhancing nodule. Also, in case of ependymoma, I will comment laterally on the area of internal auditory canal, looking for any cerebellopontine angle lesion like astrocytoma, neurofibromatosis too. And here I will look for any evidence of other gliomas especially optic, or looking for other signs of neurofibromatosis 1. So medullary lesions in the exam, describe it and try to rule out any syndromic association. The last one is a mass lesion in the chest, discovered incidentally during a patient complaining of neck pain. In such case, the lesion is small but massive edema. This is a character of metastasis. Massive cord edema relevant to the size, small size of this lesion. Our friend here missed this lesion because it's small. But remember, in the exam setting, the lesion may be present at the edge of the film. Film edge is a classic exam case. Okay, so massive cord edema in T2, look for a lesion, even a small lesion. In the localizer here, the lesion is present in the left lung, so metastasis. So a four differential diagnosis for intramedullary lesions in the spine: ependymoma, astrocytoma, hemangioblastoma, and metastasis. Okay, candidate one again. Are you with me?
Yes.
Okay, easy case inshallah. Posterior fossa. Ask for control. Okay, proceed.
All right. So I'm presented with CT of the, sorry, that was so fast. I'm presented with axial CT of the brain. In this patient, this is a pre-contrast image. So I'll quickly scroll through and okay. So I can see that there is a large mass within the fourth ventricle. So this mass is large. This mass is hyper dense to the adjacent cerebellum and expands the fourth ventricle. Oh, sorry about that. So it's a large mass and has some hypointense components around it. There is associated compression of the fourth ventricle, which is compressed anteriorly, and mild dilatation of the lateral ventricles, third and lateral ventricles, including the temporal horns. This suggests hydrocephalus.
Okay.
So I'm looking at the rest of the brain for any other associated pathology. However, I do not appreciate this. So I also look for any features to suggest tonsillar herniation.
Good.
So then in my routine practice, I also check the bone window and the contrast images. So in my routine practice, I will, because of this hydrocephalus, I will pick up the phone and inform the reference physician of my findings and recommend external ventricular drainage by the neurosurgeons.
Well
Then I
done,
will
Marcos.
compare with previous images. And
I'll
then,
give you the MRI of the same patient. Just leave the mouse.
okay.
Okay. No, leave the mouse. Okay.
Sorry, what do I do next? I should give up control, right?
Yes, yes. Okay.
Okay.
Okay. And now you can scroll. Okay.
Okay, so the MRI confirms the aforementioned mass to be isointense to the cerebellum, with the aforementioned cystic area to be hypointense as well.
Okay, I'll give you the
So,
contrast.
okay.
And now tell me what to do.
Okay, I can't scroll any. Okay, I can scroll now.
You can. Okay.
Yes. So I'll go to the region of the aforementioned mass. So the solid component shows areas of heterogeneous and enhancement.
Okay.
So I will check for extension of this lesion to the foramen of Magendie and Luschka, and there appears to be some extension.
No definite, no gross extension.
Yes. Okay. So I'll look at the ventricles to check for any seeding,
Good.
and I do not appreciate convincing features to suggest this. So in my routine practice, I also, if there are images of the spine, I also check for this. So my findings are those of a, posterior fossa mass in the fourth ventricle with heterogeneous enhancement. So I will correlate to the patient's age, but my main diagnosis is a medulloblastoma with an ependymoma being a differential.
How to
So,
differentiate between these two entities?
okay. Although a medulloblastoma, I expected it to be more avidly enhancing and less heterogeneous.
I mean, any specific MRI sequence that can help.
Oh, okay. Oh, you mean can help to do what, please?
What?
Sorry, I didn't understand the question.
Okay, any other sequence you want to see?
I would want to look at the ADC and DWI.
Yes, yes, yes. Okay, just a minute. Diffusion.
Okay, this lesion is seen to be restrictive, or it shows restricted diffusion on the DWI. However, I would like to correlate with the ADC as well.
Okay, okay. Just EDC.
Okay, it shows true diffusion restriction.
So
So
now the diagnosis is
medulloblastoma.
yes. Okay, diffusion is very important to mention. The most two important points here is diffusion and its emergency, neurosurgical emergency, as you mentioned, and ask for neural access. I will answer after the second case. Candidate two. Candidate two with me.
Yes, yes, yes.
Okay, boss, ask for control.
I have requested.
You have it.
Okay. So I'm provided with MRI brain axial images, T2 weighted images. I'm scrolling these images from top to bottom. I can see that there is heterogeneous mass lesion, which is centered in the posterior fossa, predominantly in the fourth ventricle. It is giving heterogeneous appearance on T2 weighted images with internal hyper intense areas. I can see within the lesion. I can see it is compressing and effacing the fourth ventricle. Now I would like to look for the hydrocephalus. If it is causing any hydrocephalus, I am not able to scroll
No problem.
these images to the extent, but I can see that visualized temporal horns appears slightly prominent, and there is effacement of fourth ventricle. So I'm suspecting some hydrocephalus in this patient. But I would like to, in my routine practice, I would like to see the full extent of the images. I can also see there is crowding at the mild crowding at the level of foramen magnum.
Okay, good.
And this lesion is seen to be extending through the foramens, foramen of Lushka, and
Show me this extension. Use the map.
also it is extending into the foramen magnum at this level.
Yes.
Yeah,
What about
here
foramen Loshka?
I think here I can see some extension on the right side.
Go up. Left side is more clear.
Yeah, left. There is also extension on the left side.
Okay, good.
Now
I'll give you the contrast.
yeah. Okay, now I'm looking at the post-contrast images. I can see that this lesion is showing heterogeneous post-contrast enhancement. Now I am looking for any other enhancing area other than this lesion. I cannot appreciate any lesion. So keeping in view its appearance, I am thinking of ependymoma, as it is extending through the foramens, and it is significantly compressing the fourth ventricle, and I would urgently refer this patient to the neurosurgical team for VP shunting, and I would also like to image the whole neurexis for any drop metastasis. And I would also like to see T1 weighted images to look for any hemorrhage, T1 hyperintensity to rule out any hemorrhage within this lesion. And I would refer this patient to the neurosurgical team for further management.
Very good, Yabus. Okay, starting, I will answer now, so you can leave the mouse. Okay, starting now with a posterior fossa lesion, midline space occupying lesion centered on the fourth ventricle, causing obstruction or effacement of the fourth ventricle with supratentorial hydrocephalus. Usually, if you start scrolling till the examiner, I will scroll till the end of this study, then come back to the main pathology and start to describe it. Please, my friends, don't go forward and back to the same area. It leaves a bad idea, okay? So concentrate on this lesion and mention the importance of hydrocephalus, because this is considered neurosurgical emergency. We have 3 neurosurgical emergencies with letter H: hydrocephalus, hemorrhage, and brain herniation. Okay, like tonsillar herniation in this case. This case is slightly hyper dense, like bagged cells tumor, like myelanoblastoma. If there is cystic spaces or calcification or hemorrhage, you may suspect ependymoma first. Okay. In MRI, the most important sequence after contrast is a diffusion, because medulloblastoma. Okay. Okay. Medulloblastoma is a heavily packed tumor, highly cellular, so most likely cause diffusion restriction. Okay, a question for you, my friends. What other brain tumors that may restrict?
Lymphoma.
Okay, so medulloblastoma, lymphoma, any other lesions?
GBM.
Glioblastoma? Unlikely. Okay, what else?
Okay.
Suspect atypical rhabdoid.
Yes. Meningioma. Okay, good.
Anioblastoma.
Okay.
Anaplastic astrocytoma.
Ependymoma grade 3 or 4. ماشي. Okay. And there is non-neoplastic lesion. You forget yes, epidermoid.
Abscess.
Epidermoid. And
Epidermoid cyst.
good.
Epidermoid cyst.
Good. Very good. Okay. Back again. Medulloblastoma, it will restrict and it doesn't extend along the foramina. Very good point to mention. Unlike ependymoma. Ependymoma, it was a foraminal extension inferiorly in the midline foramen of Magendie. This is not a crowding due to tonsillar herniation. It's the inferior extension of the lesion. It's enhancing lesion in the foramen magnum. So this is the inferior extension, or what's called foramen of Magendie extension. And there is lateral extension foramen of Loschka. Remember, lateral Loschka, midline Magendie. So I have here a feature suggestive of ependymoma. Another feature, absence of diffusion restriction. It doesn't take a high signal in the diffusion weighted images. Okay, and if heterogeneous heterogeneity within this lesion. So the most common 2 lesions in the midline, medulloblastoma and ependymoma. Another lesion for candidate 3. Okay, this is an adult patient.
If requested, remote control.
I accept it.
Sorry. Can provide with axial images, MRI. This is at T1 post-contrast images. I would like to go through the wall images first before describing any abnormality. I'm going downward, so it's very slow and scrolling.
Take your
I guess
time.
I can't see that there is a homogeneously enhancing lesion that is seen to be within the fourth ventricle. This lesion is expanding the fourth ventricle. Would like to go downward to check the expansion of this lesion. I can't see that what is seen to be crowding of the foramen magnum was there
Good,
is a capsular herniation, and
good.
I'm going upward. And I can't see as well that there is prominent temporal horn of the lateral ventricles, so this indicates with a placement of the fourth ventricle. This is a ventricular dilatation of hydrocephalus, secondary to the mass region. And again, upward, I couldn't see any other similar lesion within the brain, no evidence of extraaxial hemorrhage, no evidence of uh, other brain herniation. Now see what seemed to be
Don't go back and forth many times.
okay.
Just one time until the examiner, okay, I will review another time, not more.
Okay.
Okay,
So conclusively, I can't see what seemed to be homogeneity enhancing lesions that is seen within the fourth ventricle, with positive mass effect and hydrocephalic changes as well as tonsillar herniation. This is an emergency. I'm going to pick up my phone and inform the neurosurgical team because this patient will require urgent VP shunt insertion. As regards the region, due to the homogeneous post-contrast enhancement, in my routine practice, I would like to correlate with the CT images if present, because I'm very concerned in the post-contrast enhancement about meningioma.
good, good
Great plexus
definition.
papilloma. Great plexus papilloma is also one of the
Very
differential
good.
diagnoses, especially in adult patients affecting the fourth ventricle.
Very good,
Uh,
Yafos.
in
Accepted
my
two
routine
differential.
practice,
Accepted two differential. It's a case of choroid plexus papilloma in adult patient. Choroid plexus papilloma, it can come in the fourth ventricle. Okay, I will take my mouse back.
I think in correct plexus papilloma we should also image the whole neural axis because it's also associated with
Okay.
uh,
Yes,
section.
I forgot to mention this point. It's a very important point, my friends, to mention imaging of the whole neural axis in a space occupying lesion in the posterior fossa, enhancing, mention this point. Imaging of the whole neural axis because of drop metastasis. Very good, Yabus. Very good. Candidate 4. Candidate 4. Okay.
Yes, sir.
You have the scroll. Start, Yabus.
Yeah. I'm provided with actual T1 weighted MRI of adult patient. I would like to scroll through the images first before commenting. Uh, as I'm scrolling, I can see a well-defined lobulated T1 hypointense lesion in the region of fourth ventricle. I'm not able to appreciate the fourth ventricle separately from the lesion. The lesion is extending inferiorly into the foramen of Magendie and extends laterally into the foramen of Lashka.
Are you
I would
sure?
like to review the T2 weighted and diffusion images of this patient.
I'll give you the diffusion.
On diffusion weighted images, the lesion shows diffusion restriction, which in my routine practice, I would like to correlate with the ADC maps as well. So, based on these imaging findings, my most likely diagnosis is intraventricular epidermoid cyst. However, I would like to correlate with the ADC maps as well.
Excellent, Yabus. Excellent. It's this lesion hypo in T1, non-enhancing in the post contrast, very high T2. It's mimicking the CSF signal, so the diffusion will be conclusive in this case. Remember, epidermoid is a great mimicker. It can come in many areas. This is an example of typical case in atypical location. The typical location of epidermoid is what? Where is the typical location of epidermoid?
Extraaxial.
Yes, excellent, excellent. Cerebellopontine angle is the typical location, not in the fourth ventricle, not in the pineal body, not in the cellular or supracellular region, but it has a typical criteria. Okay, cyst mimicking CSF in T1 and in T2, not in flare, with restricted diffusion. Okay, thank you, candidate 124. Thank you.